5, 4, 3, 2, 1. We are live now.
Thank you. So I welcome you all for this webinar, and this is the fourth lecture in the series by Wockhardt Limited. I, Dr. Ravi Gaudi, welcome you all on the behalf of Wockhardt for this academic program. Today, we will have a very practical lecture by Dr. Ananda Kisor Pal, and he will be enlightening us on the topic that is very practical. That's practical aspects of early diagnosis and prediction of rapid progression of osteoarthritis of knee and treatment strategies for the same. So I will take a pleasure to introduce Dr. Pal, and Dr. Pal is a very well-known face and very active in academia. So currently he is Vice President of West Bengal Orthopaedic Association. Dr. Pal is MS Ortho and also DNB. He has also done MNAMS. Then he has delivered many lectures in national and international congresses. So he conducts regular programs like AO Basic, Advanced and Master courses. There are 43 international and national publications to his credit. He is also author of book An Atlas of Orthopaedic Radiology and Common Orthopaedic Disease Clinical Guide. So his talk will be more focused on practical aspects and that can be implemented in clinical practice. He was also selected as one of the inspiring orthopedician of India for the year 2019 by Economic Times. Now acting as professor and head, Department of Orthopaedics, Jalpaiguri Medical College, and he is also former head and of Department of Orthopaedics and Traumatology, IPGMR, SSKM Medical College, the Center of Excellence, Kolkata, West Bengal. He has many awards to his credit and gold medals also. So we have a very academically sound, practically competent, having a rich experience faculty today to enlighten us on a very practical topic. So with that, I request Professor Pal to take the lecture forward, and I welcome him once again on the behalf of Wockhardt as well as OrthoTV to deliver his talk. So I stop sharing over here, and he can share his screen. Over to you, sir.
Okay, thank
you. And I will request to all the audiences to put their questions in the chat box. At the end of a session, we will take it with Pal sir, and we will have a nice academic discussion too. Over to you, sir. Thank you.
Good evening, everybody. Is it, am I audible and visible?
Yes, sir. You are audible and visible too.
Okay. Thank you. So good evening, everybody. So welcome to my lecture, because this is a very, very informative lecture, I think, because everybody tries to management of osteoarthrosis, basically ultimately, which is ultimately the joint replacement. But now in this evening, ladies and gentlemen, we will discuss with the early diagnosis and the prediction of the progression and to prevent the development of the end-stage arthritis, and thus we can escape the joint replacement. So apart from the surgical treatment, we will discuss how it can be prevented and what is the plan of management at this stage. So what is osteoarthrosis? Osteoarthrosis is basically culmination of the multivariate interactions between the genetic, epigenetic, environmental factors, extrinsic factors like obesity, trauma, joint loading patterns, known as the heightened wear risk, and often more definable targets of the disease modification. Unfortunately, the radiograph that can diagnose the irreversible stage. So once it is diagnosed in radiograph, so there is very, very little to be done for prevention to coming into the end stage. So in the early stage, when the patient comes, the radiographs are inconclusive. That is why we are here, ladies and gentlemen, so to understand how the disease progresses, how the disease occurs, and in the early stage, how will you diagnose this and how will you prevent its progression? You cannot prevent its ultimate fate if it is neglected, but there is lots to be done for prevention of its progression. Now, for an outset, I have to discuss the terminology. What is the osteoarthrosis and what is arthritis? Osteoarthrosis primarily it is a degenerative disorders because osis means the degeneration, whereas osteoarthritis is a degenerative arthritis. It is a disease of the articular cartilage which doesn't have the blood supply, lymphatic supply, the nerve supply. So how the inflammation sets in? Osteoarthrosis, basically, yes, that comes first. This is the same answer. Somebody's asked whether the term is arthrosis or arthritis. Which one is the primary? Which one is the secondary? Arthrosis is the primary one because there's a degenerative process. Once the inflammation sets in, that is the degenerative arthritis develops. So osteoarthrosis is a dynamic disorder with features of both the destruction and repair. Now, pathogenesis. What is the pathogenesis? This is for the academic interest. Basically, there is senescent cells, cartilage cells. They lose their capacity to maintain the repair of the extracellular matrix. That it is diagnosed. It is reported by the Movasari. Whereas the ECM is the extracellular matrix undergoes the changes with the age, such as alteration in the composition and the structure of the proteins and the proteoglycans. This is the most important, which is dependent on the vitamin C, which is responsible for this healthy production of these proteoglycans, surface fibrillation, increase of the cross-linking of the collagen, as also resulting in the reduction of the tensile strength. So basically, if you see the pathogenesis, there is basically the proteoglycan matrix depletion lies in the center. That leads to cartilage deformation. That causes the cartilage failure. Again, it stimulates the proteoglycan matrix depletion. Once there is a significant depletion, that causes the chondrocyte damage from more load of the joint or eccentric loading of the joint, less contact area from incongruity or the instability or change in the subchondral bone. Ultimately, because of this damage of the cartilage, that produces the release of the proteolytic enzymes, and that causes further damage of the proteolytic, and the vicious cycle goes on and on and on. So basically, how to diagnose histopathologically? Histopathologically, once there is a cartilage, this proteoglycan is depleted, or there is a loss of water from this cartilage, there is a cluster, the chondrocytes becomes conglomerated, and basically there is a patchy loss of metachromatia, leads to increased cellularity as there is a loss of water and the proteoglycans. That leads to clusters of the clones of the chondrocyte. If it is 20 or more, that is located just in the subchondral area in the cartilage. As you can see here, is the cartilage. It's in this electron microscope, as you will see like this by special strain, and that leads to increased cellularity. It is suggesting of this sort of degeneration. Now, is it a hopeless situation? No. So there are some even in the midst of the hopeless, there is some good news because remodeling is possible. Yes, remodeling is possible. And depending on the remodeling, we can divide the disease into the atrophic arthritis or the hypertrophic arthritis. Atrophic osteoarthritis is basically, unfortunately, it is very low. There is 20%. That once there is a destruction is more than the remodeling, whereas the in atrophic arthritis, the remodeling is more than destruction. So there's hypertrophic arthritis. So we have to understand. So those who are the cases who leads to hypertrophic arthritis, and that these are the hypertrophic arthritis leads to severe pain, ultimately leads to end-stage arthritis. Now there's a grading. I'm not going. This is a very, very busy slide. Now I'm going to discuss on this. So there are some grading of the articular cartilage destruction in the early stage. Now we are going to the pictorial description. So the articular cartilage destruction can be divided into 6 stages. It goes maybe very slowly or maybe very rapidly. So you have to understand, we have to pick up those candidates who are very rapid progressors. Some are very slow progressors, some are very rapid progressors. So basically there are 6 stages of the articular cartilage damage. So initially, once the cartilage is damaged, there is a proteolytic enzymes I've already discussed. They're coming out, that proteolytic enzymes, as also the abnormal mechanical stress, leads to the gradual denudation of the articular cartilage. So if you see these articular cartilage, the grade 1, so there are very minimal amount of changes in the surface. And in the grade 2, there is a very little amount of changes in the surface. The gradual is a loss of very surface component of the articular cartilage. Now, in this stage, there is symptoms. But what are the symptoms? I'll discuss. In this case, there's a symptoms, but by investigational parameters, very difficult to prove the patient has osteoarthrosis. Now, these are the candidates we have to pick up. So how it can be picked up, we'll discuss in the next coming couple of minutes. Now, in the stage 3, see the stage, there is already stage 2. Now, this is stage 3 and the stage 4. Then there is a surface fissure, it's incomplete, whereas there's a complete surface fissure where there is a liberation of the proteolytic enzymes. Now, this is the stage where the patient is gradually coming into the irreversible stage. So, surface fissure, once it is incomplete or the complete, there's a patient is gradually entering into the irreversible stage. And the symptoms of osteoarthrosis starts to develop up to this level. And in the arthritis, once the cartilage denudation product, that leads to inflammation, initially leads to synovitis, followed by the arthritis. So in this stage, the previous term, grade 1, grade 2, so there are some symptoms I will discuss. What are the symptoms? In the arthrosis stage, is early synovitis, and suppose it is an advanced fibrillation stage, there is a possibility of early arthritis. Whereas in the stage 5 and the stage 6, it is completely irreversible stage or the end stage arthritis. As you can see here, there's almost all the surface component of the articular cartilage is completely denuded. Not only that, the subchondral bones are also damaged. So these are the end stage arthritis. So there are 6 stages of the osteoarthrosis, and that leads to these 5 and 6 stages, the end stage arthritis, and then recurrent synovitis. If there is a recurrent synovitis, that leads to rapid progression. So how this synovitis can be diagnosed and how it can be picked up from clinically and from the investigation parameter, this is the point of interest. Now, can osteoarthrosis be diagnosed in the arthrosis stage before reaching to the arthritis? And that is the answer that remains in the same questions. What is the cause of pain in the osteoarthrosis? Is it the synovitis or the arthritis or anything else? Now, how do you diagnose the synovitis and arthritis? Now, arthritis means arthritis is likely when the pain is aggravated by the movement. So pain aggravated by the movement. When the patient remains in the rest, there is no movement, no movement, no pain. When the patient starts movement, patient will complain of pain. So this is the basically pain aggravated by the movement, is associated with loss of motion and is accompanied by swelling and the erythema. That is the stage of arthritis. That is the irreversible stage has developed. Now, if the joint motion is preserved, but the tenderness can be elicited then by palpation over one of the regional bursa, tendon, or the ligaments, it is unlikely that the joint pain is due to arthritis. So how the synovitis can be diagnosed? So if there is a pain, the range of motion terminally painful and restricted, localized joint line tenderness, basically it is due to arthritis. Now the question is, how will you differentiate the pain from the synovitis and pain from the arthritis? Now this is the very important slide. So clinical clues for diagnosis of early osteoarthrosis or the osteoarthritis. Now in osteoarthrosis stage, basically the symptoms are in intermittent episodes. Whereas in arthritis stage, there may be possibility of constant feature. They're the red flags. I will come. So basically in arthrosis stage, suppose in stage 1, stage 2 arthrosis, how can it be diagnosed? This is the most important symptoms. There is occasional pain following inactivity. So if the patient sits for a long time, suppose after 30 minutes, so if the patient sits 30-40 minutes, patient sits in a chair, once the patient is started walking, the patient will complain of pain. So initially patient will complain of pain. Once the patient continues the walking, then the pain goes off. So pain following inactivity, it is a basic symptoms of osteoarthrosis. And the other symptoms, like there is a gradual, the walking speed is gradually reducing. The patient is not walking, it is normal speed. This is very, very important, because the patient is, once the patient is walking, but because of this, the pain is generating from the knee joint, that the muscles are going to become pain spasm cycle, and that the muscles are early fatigued. So there is a gradually reduction of the speed of the patient. That is also another symptoms of the osteoarthrosis. Ultimately, patient will be unable to stand for prolonged period, and pain during use of the staircase. See, these are the features of early stages. Whereas the patient reaches into arthritis stage, so the patient has a chronic pain, chronic knee pain, is a dull ache or burning pain, acute exacerbation of the chronic pain with intermittent swelling, and there's a severe painful restriction of the joint motion. These are the red flag signs. That means patient has been reached into the irreversible stage, and that has to be investigated properly. Because unfortunately, the radiological feature does not correlate with the clinical features. That is the most important drawback. So that is why we have to keep our expertise for detection by the clinical responses. Now, what are the risk factors for development of osteoarthrosis? There are several extrinsic factors like trauma, malunited intra-articular fracture, occupation with repetitive stress and overuse, family history that leads to polyarticular osteoarthrosis. Intrinsic factors like the joint dysplasia, increased bone density, and obesity, especially in the female. So is it a genetic? Yes, there are several genes that are identified, of which most important is a variant of the MCF2L gene, which is found in the chromosome 13, which regulates the nerve growth factor, and ultimately that leads to the production of the that remains in the production of the extracellular matrix, and that leads to be that remains behind the senescence of the chondrocyte also. So another is a monoclonal antibody against the nerve growth factor, relieve the pain and improve function. So these are the actual evidence that it is a genetic predisposition. Now, there are other predisposing factors like some occupation, which causes the repetitive load on the knee like this. So this is very, very important. Another is the increased acute and the direct joint impact or the torsional load, which is basically visible in different different sorts of soccers, baseball, skiing, and the rugby. That leads to ACL and the meniscal injury, which reduces the shock absorbing property of the joint, and that leads to predisposed to osteoarthrosis, which is already diagnosed by several workers. It is highlighted by the Gilbert and the Brown. Now, diet and obesity. See, the low intake of the vitamin D and the vitamin C is a possible risk factors for the knee osteoarthrosis, because there is a direct relationship of the vitamin D with the osteoporosis, which leads to sarcopenia. That is, number of muscle cells will reduce. So there is as the muscle cell becomes weak, there is increasing load on the bones. So in the load on the bones, the articular cartilage becomes damaged. Another is the vitamin C, which is already told. Vitamin C is responsible for the proteoglycan formation. That is it is a triple helix. So that leads to for healthy triple helix formation of the proteoglycan. Vitamin C is absolutely essential. Which certain food groups like the milk and the dairy products, meat and poultry are the beneficial for the knee osteoarthrosis. Another is the obesity. Obesity, inactivity, and the muscle weakness increase the person's chance of developing osteoarthrosis, because overload on the weight-bearing joints activates the chondrocytes and accelerates the cartilage degeneration. Now, how the obesity leads to the osteoarthritis at the cell level. So this is very, very important to see. This slide is absolutely important, especially those who are obese, because now in our society we are having the childhood obesity is a very, very important factors are coming in a very big way. There's a strong metabolic link between the obesity and the osteoarthrosis that can be represented by the adipokines, and that list such as the leptin, adiponectin, resistin, and the bispectin. So there's articular tissues with the strong structural and the biochemical changes show a less regulated leptin expression in comparison with the normal tissues, and the level of the leptin expression is proportional with the grade of the cartilage destruction. This is very, very important. And consequently, those are the growth factors like the insulin-like growth factor 1 and the transforming growth factor beta 2. And excess of leptin So the leptin is also responsible for the ECF, that is extracellular matrix formation, but in the excess of leptin also that can reduce the extracellular matrix synthesis, leads to increased susceptibility to the joint, to the lesions producing the inflammatory cytokines like interleukin-1 and the nitrous oxide, which reduces the chondrocyte function and ultimately depletes the extracellular matrix. So adjust the absolute, the balance of the leptin is absolutely essential for healthy extracellular matrix inside the articular cartilage. So that is extremely important. Now they come to the imaging. Basically, these are the the hallmarks of the radiological parameters for diagnosis of the osteoarthrosis, as in the joint space reduction, subchondral bone there is sclerosis, cyst formation, and the osteophytes. These are the 4 parameters of the radiological diagnosis. There are several investigations like conventional radiograph and the full length radiograph, but unfortunately, they cannot detect the early synovitis, and the first radiological sign is the reduction of the joint space, which is a very, very advanced stage. So this joint space reduction it starts in the posterior compartment, but conventional radiograph cannot diagnose the posterior compartmental reduction, because that is very, very important. And see this structure, see this picture. Suppose in most of the cases in any osteoarthrosis, if you see this lateral profile, you will see there is a little bit of flexion deformities already developed, especially once the patient is complaining of recurrent pain and the swelling. So if there is swelling, there is a effusion formation. All of you know, because of the effusion, the joint comes into the position of the maximum capacity, that is the flexion. Now, if there's a flexion is developed, that is a loss of extension, is the most important prediction factor for the progression of the osteoarthrosis, because the lower posterior condyles becomes affected, and the posterior condyle reduction of the joint space in the posterior condyle is the most important, the first sign of the reduction of the joint space. So how will you detect it? So detection of the early osteoarthrosis by conventional radiograph is impossible. Now this is the view, is a Rosenberg view. This Rosenberg view can be easily taken by in this manner. That is a 30 to 45 degree flexion, and then this X-ray cassette is kept. It is placed with the support of the wall, and the X-ray is placed in this manner. This is 10 degree. It is a caudal, and basically in this way, if you check, so there is a certain reduction of the joint space, which is absolutely absent in case of conventional radiograph. See, this is a conventional radiograph. The medial joint space is absolutely maintained, whereas in the medial joint space is reduced in case of this Rosenberg view. See, this is the case. This is a real-time case. This is a 59 years lady. It came to us, came to me. That is with pain following inactivity. But this the initial radiograph is absolutely normal. This is a non-weight bearing radiograph. The anteroposterior and the lateral, perhaps the radiographer has taken it because the patient is unable to stand because of the pain. Now the standard AP standing view shows, see, there is a not significant reduction of the medial joint space. Whereas the Rosenberg view, when I'm doing the Rosenberg view, you can compare this reduction of the medial joint space with the same patient. You can see the significant reduction of the medial joint space if you compare with the normal side. So this is the Rosenberg view. Is early diagnosis is possible, but still it is little bit late. So if the early surface changes of the articular cartilage can be detected, yes, there are some higher investigations. Radionuclide scanning, that is the 99 technetium HDP shows the increased activity of the bone phase, but it is not commonly done because there are several other parameters to be checked, like kidney function, renal function, everything. But so there's a non-invasive investigation like the CT and MRI is for the early detection. See this case, as you can see, there is obvious significant irregularity of the articular surface. So this is a much more advanced stage. So what about the earlier stage? So MRI, being a non-invasive cross-sectional imaging technology, suffers from low resolution and the inability to standard MRI to discern the matrix changes leading to cartilage softening. And see, this is the T2 weighted image as is water looking bright. As you can see here, there's a reduction of the thickness of the articular cartilage. It is appreciable on this side. But most important is the T2 mapping, as you can show here. This is because T2 is sensitive to tissue hydration and collagen tired matrix organization, but it is an indirect evidence. Whereas in the proteoglycan depletion, so proteoglycan depletion is directly measured with the help of this T1 row mapping, because T1 row may be sensitive to the proteoglycan content. And see, this is the T1 mapping. As they see the joint fluid is it is looking dark, so it is a T1 mapping. And in this case, you can see the increased thickness of the non-weight bearing anterior condyles, whereas in the posterior condyles, see the thickness is reduced, and that can diagnose the earlier the detection of the cartilage damage. Another way is the invasive way of the cartilage disease is a naked eye picture by the use of the arthroscopy. And during the arthroscopy, the macroscopic cartilage damage is graded from 0 to 4 using the Outbridge scoring system, whereas 0 means the firm cartilage, 1 means the softening, 2 is the fissuring. So as you can see here, there is a fissuring. But it is less than 50% of the cartilage thickness. 3 is the fissuring, which is more than 50% of the cartilage thickness, and 4 is the exposed bone. So this is this stage. The 0, there is 1 is a fissuring, there is a less than 50%, fissuring more than 50%, and the 4 is the exposed bone. Still, so is it possible? It is a surface change. So in this stage, patient has come with a severe painful restriction. So is it possible to diagnose? Yes, there are several other investigation is coming in the big way. So this is early detection of the microscopic cartilage damage in the surface. It is possible, and that is on the basis of this theory. There is knowledge. This articular cartilage exhibits the natural birefringence that is detectable by the light microscopy due to the organization of its collagen fibrils. This is the healthy cartilage. See, if it is these birefringence models with the under the electron microscope, you can check easily these birefringence models. You can see here there are the two bands, so it can be easily identifiable. Now, what is the method of investigation? Method of investigation is the optical coherence tomography. It is a new high-resolution imaging technology which pertaining the microscopic cross-sectional imaging of the soft tissues in a near real time has been used arthroscopically. So basically, it is a non-destructive. It is an invasive procedure, but it is a non-destructive. So it doesn't take the biopsy. But without taking the biopsy from the surface, it can easily detect this birefringence if it is a normal one. So through this arthroscopic portal, we can use this optical coherence tomography that can be coupled, if it's coupled with the arthroscopic. So that is a translational research tool to assess the evaluating the quantitative MRI of the articular cartilage. And this it is established by the Chu 2010. And this is it is almost established by the arthritic articular cartilage as detected by the polarized microscopy is detectable by this polarization sensitive. There is an optical coherence tomography. There is an insertions we can tell PSOCT as a loss of normal form of birefringence. So this is a healthy cartilage, but with the help of this arthroscopic portal, if we do this optical coherence tomography, then this picture will look like this. So if it is seen, so then we can understand there is a possibility of already the degeneration has been started. Now, how do you correlate with this? So this is you can correlate with the arthroscopic image, while as this orthopedic tomography, and also the T2 and MRI image. As you can see here, it is easily detect this loss of birefringence. So this optical coherence tomography, as you can see here. So this is the articular cartilage mapping in the MRI, but you cannot detect the difference between this early stage. See, this is a 0 stage. There is no fissuring. There is a surface fissuring. There is a surface fissuring less than 50%. It is only it is surface. The degeneration has been started. So it is 0. It is 1 and 0 is a 2. But see, so in the MRI, they can detect this, but there is no difference of this. So what is the earlier stage? What is the advanced stage? You cannot differentiate. Whereas this study, this optical tomography, you can easily understand. See, this is the birefringence. You can easily detect it. It is loss of birefringence. Whereas the surface fissuring, it can be easily demonstrated, which is lacking in case of arthroscopy as well as the MRI. So this is the very, very useful tool, the optical tomography. Arthroscopically, we can easily detect the early change of the articular cartilage. Now, another tool is coming. there is a delayed gadolinium enhanced MRI of the articular cartilage. That is, in short form, it is known as a DGE MRI. See, this is a DG Medic in the study of the early knee osteoarthrosis, and this is a linear dose-dependent distribution of the gadolinium DTPA. It is basically a negatively charged particle. Now see, the proteoglycans in the articular cartilage is a negatively charged. If the articular cartilage are healthy, that means it is composed of almost all normal negatively charged proteoglycans. So in that case, so if we infuse this in the blood, they will not allow to go inside, because negative ion, normal negatively charged glycosaminoglycans, they repels that is gadolinium type DTPA. But if it is devoid of, articular cartilage is devoid of this negatively charged the glycosaminoglycans, so in that case, so this articular cartilage can take up this negatively charged particle gadolinium, and this, if it is a delayed image we can take, so it requires some time. So it is we can delayed image, at least after 24 hours to 2 days, we can easily diagnose by the cartilage which are unhealthy. So damaged cartilage with deficient GAG, there's a high intake of negatively charged gadolinium DTPA, and this delayed image can easily diagnose this sort of articular cartilage damage. Now, this is very, very important, because it can correlate with the rehabilitation. Among the meniscectomy subjects, examination of the DG Medic study before and after 4-month change in exercise regimen found that the subjects who increased their exercise level experienced a concurrent increase in the DG Medic index, indicating the increase in glycosaminoglycan content. So initially, see, in this case, it is before exercise. So initially, immediately after the operation, so is once the patient starts exercise. So this is the picture you can see here. These areas are devoid of the articular cartilage because there's a proteoglycans are lacking. So it's taking the images. But after 4 months, it is not taking. The amount of this GAG is very, very less inside the articular cartilage. That means articular cartilage is trying to synthesize the proteoglycans under the influence of the exercise, and that is the influence of the exercise. How the exercise will increase the cartilage the property, I'll tell you. There's some evidence. Now we have come to the progression of the osteoarthrosis. Who are prone to progress? Which occupations are very much prone to progress? Is there any predisposing factors? Yes, the risk factors of the progressions. The risk factors for developing osteoarthritis may differ from the risk factors for the progression and the poor clinical outcome. There's as high bone density is a risk factors for development, but the low bone density is a risk factor for progression for the knee and the hip osteoarthrosis. That means the knowledge, including the treatments for the osteoarthritis as one joint site, cannot necessarily be extrapolated to all the joint sites. So see, this is the factor. This is a 47 years old man has a chronic knee pain with sudden intense swelling, and see, this is the synovitis. It is this is the synovial fluid is coming out. So this is basically it is a recurrent synovitis. So there's a factor of progression. First important factor is the recurrent synovitis. Another important factor I've already discussed. See, this is the 62 years old male had the low back pain for 10 years, pain on both knee for 7 years. This is a painful swelling of the right knee with see, this is the function, this is a flexion deformity, flexion, there's a loss of extension. So so this is also the second factors which leads to progression of the osteoarthrosis. As I already told, every single degree of loss of extension leads to progression of the osteoarthrosis, and that can be easily picked up with the Rosenberg view or with the help of the MRI or some CT. Why it happens? Why the flexion deformity that is to progression of the osteoarthrosis? So we have to understand the coxospinal relationship. See, this is the normal spine. So this is a normal spine, this is normal lumbar lordosis. So if any disease that leads to reduction of the lumbar lordosis, that leads to some posterior tilt of the sacrum. See, the posterior tilt of the sacrum that can be accommodated with the help of the extension. So we can have, all of you know, we have only 15-degree hip extension. So this posterior tilt of the sacrum that can be compensated by the hip extension up to 15 degree. But if it is much more posterior tilt, as you can see here, as a much more posterior tilt can develop because of the severe disease of this lumbar spine, as the prolapse, disprolapse, or the spondyloarthropathy. So what will happen? So the patient will the leaning forward. So leaning forward posture. So in that case, so we have to make the balance. Once the 15-degree extension is completely washed out, so the patient will need to flex the knee for making the balance, so that the head remains in just over the foot area, so that the balance is sagittal balance is maintained. So this is the basically is the coxofemoral spinal relationship. So any disease of the lumbar spine which leads to reduction of the lumbar lordosis, so that leads to ultimately flexion of the knee. And if once I already told, if there is flexion of the knee is the most important, there is a loss of extension of the knee is the most important another factor for progression of the osteoarthrosis of the knee. So beware of that. So if there's a patient is complaining of low back pain for a long time, that has to be corrected before damaging the knee joint. So this is most important. Now, how the high body weight or the BMI operate? By BMI or the high body weight operate directly by the high loading on the articular cartilage that leads to primary osteoarthrosis, or indirectly by damaging the extra cartilage soft tissue structures within the joint, that will subsequently lead to the joint instability and the secondary osteoarthrosis. So again, I will come how the increased body weight that can damage the articular cartilage. Now, if there is any screening test, so is there a screening test to diagnose whether the patient is going to progress? Yes, there is a screening test. There's single leg stance. So single leg stance is a performance that you have to ask the patient to lift the hip and the knee, to flex both the hip and knee at 90 degree, and we have to keep this posture for at least 10 seconds. And so you have to see the scoring with that depending on the parameters. There's a no loss of height or slumping forward, stable balance, there's a symmetrical, or look for the excessive effort. But if the patient is unable to stand, so these are the parameters. If the patient is unable to stand, or there's an asymmetrical balance, that means that the muscle power is less. And if the muscle power is less, that means there is an increased loading of the bones when during the weight bearing, and these patients are likely to progress or rapidly end-stage arthritis. Now, this is another interesting study. It is the finger hand. This handy guide. So you have to check the length of the height of the index and the ring finger. Index finger is normally the height of the index finger is more than the ring finger in case of male, because index finger is basically under the influence of the testosterone in the mother's womb. So in male, this is the male type of finger. So in the index finger height is more than the ring finger. But if sorry, just have given the just opposite. The ring finger is normally it is at is a much more height than the index finger, because of the ring finger is basically it is under the influence of the sex that is testosterone in the mother's womb. But if it is just opposite, becomes ring finger is reduced, and the ring finger that is a female type of finger, because in the female type of finger as there is lack of testosterone, so there is the height of the ring finger is less. Now we can assess the height of the index finger and the ring finger. Now, more height of the index finger in the female, it is basically leads to osteoarthrosis of the knee. Whereas more height of the index finger in the male leads to Herd's disease, because more index finger is height is more, that means ring finger height is less. That means a ring finger is under the influence of the testosterone. So if the ring finger height is less, that means the testosterone level is less. And all of you know the testosterone that protects the heart. So if the height of the ring finger is less in case of male, that means there is a high chance of heart disease. Whereas in the more height of the index finger, that is basically it is in case of female leads to osteoarthrosis of the knee. There is a handy guide. Another is the factors for progression is a full length radiograph. If there is any deformity that underneath the knees, as you can see here, this is the tibia vera. Or this any deformity just above the knee, that is, as you can see here, that has to be corrected. Otherwise, that leads to eccentric loading of the joint, leads to rapidly progressive osteoarthrosis. Now, is the early diagnosis of synovitis is possible? Is the quantification of such finding is possible for progression of the osteoarthrosis in future? Or how to predict the progression? This is the questions. Now, early diagnosis, yes, Synovitis is possible with the help of the MRI. This is the DG MRI already told. Dynamic and another is a dynamic enhanced MRI. This is a DMRI. Is a technique which can quantify the amount of synovitis in the weight-bearing areas of the condyles. So joint diffusion is the best detected on the fat-suppressed PD or the T2-weighted fat-suppressed images. So that you can see here the synovitis, especially in the weight-bearing areas, if it is much more, that can be quantified, and there is the factors for progression of the osteoarthrosis. So how to predict the progression? This is another, apart from the quantification of the synovitis, if the subchondral bone lesion, see this is the subchondral bone lesion, the altered echo texture, as you can see, you can read from your MRI report. Then most of the cases we neglect them, but don't neglect this, because if these are under the weight bearing area, especially on the medial condyle, these are the signs of progression of the osteoarthrosis. This is the reduced bone marrow lesion size associated with reduction of the cartilage degradation measured by the urinary excretion. These are very the predictors for progression of the osteoarthrosis. And the pain correlates with the lesion size. And this is already diagnosed by the Lotke, which is 2000, and the lesion size is more than 1 centimeter is correlate directly with the cartilage loss if it is under the weight-bearing condyles. So these are the much more important predicting factors for progression of the osteoarthrosis. Now the management. Now management, all of you know, this is the standard management protocols, the pharmacological methods, surgical methods, and the conservative methods like NSAIDs, opioids, DMOids. But though the DMOids are not very effective for the management of the osteoarthrosis, there are counter-irritant topical creams, hyaluronic acids, steroids, oral and the intra-articular steroid. Surgical methods like arthroscopic debridement, irrigation, osteotomy, arthroplasty, and arthrodesis. And conservative means that there is orthotic joint load, there is unloaded brace, as you can see here, physical therapies, exercise stretching. These are the standard management. Now the question of the non-surgical, I've already told, we are here to identify the early osteoarthrosis. Now, can the progression be prevented? This is very important questions. Now, the early treatment, no drug can stop or cure the osteoarthrosis. So basically, all medications are the symptomatic for the symptomatic improvement, but the principles of the osteoarthrosis management. So if the patient, we can diagnose the patient has come in the osteoarthrosis stage, we have to maintain the movement and the muscle strength, so to reduce the load on the bones, protect the joint from the overload by modifying this behavioral activity. We have to relieve the pain, modify the daily activities, and yoga and pilates. It is extremely important to increase the flexibility and reduce the muscle spasm, so that will help to unload the bones. Now exercises, we have to, what are the do's and don'ts? Do's basically is the muscle strengthening, aerobic exercise, range of motion exercise, posture and the gait control. It is extremely important, posture and gait control. So actually in my practice, I ask the patient to work on the soft surface, like the ground, that on the where there is a grass, is a pull up grass. It's a soft surface. If the patient walks on the soft surface, so there is a tendency to fall, and then that leads to postural like exercises. Basically, it is unknowingly patient, if he walks on the uneven and soft surfaces over the ground, the paddy ground, so the patient easily their muscles are being stronger, ligaments are being stronger. That leads to unloading of the bones. Don'ts means over exercise. Once you have diagnosis of osteoarthrosis, don't over exercise. And there's exercise during the painful episode is absolutely abundant. Exercise which increase the impact loading, like jumping or any type of strenuous exercise should be banned. Once you have diagnosed, you have going to become an osteoarthrosis or osteoarthritis. Now, how to reduce the load reduction? So for the joints, the rate of the cartilage loss, we have to body weight reduction, wearing the shock absorbing shoes, avoid the climbing stairs, use of the walking sticks and the grab bars. As you can see here, with older patients, we have used the grab bars. We have to ask the patient to rest our limbs on the surface, so that there will be reduced strain on the axial joints. We have to use the proper use of the cane. And the walking stick is extremely important. And see, this is because otherwise that will lead to much more damage to the joint. Now, this is the lifestyle modification, as you can see here. Now, the computer syndrome, the most of the computers over the world, there's over 25 to 50% patients, 50% persons are affecting pain after prolonged use of the computer. So sometimes it is known as a computer disease. So because of the continuous use of these hands, patient may complain of pain over the thumb or the base of the thumb. So all the joints behind the base of the thumb that can cause pain in this side. Or ultimately, patient may complain of pain in the back of the neck. That's it. Sometimes if it continuous use of the mobile phone, that can be considered as a neck. That is text neck. Now, the ideal sitting position, as you can see here, this is the ideal sitting position. Your computer screen should be at the level of the eye level. There should be a hand rest, so that there's the actual unloading will be there, and there's some space for movement of the knee joint, so that ultimately that will help in some movement. This movement is extremely important, because this movement causes the recirculation of the synovial fluid. Because the articular cartilage, already discussed, articular cartilage is devoid of the blood supply, nerve supply, and the lymphatic supply. So how do they get the nutrition? So they get nutrition from the synovial fluid. So once the synovial fluid is recirculated by movement of the knee joint, that can lead to some nutritional supplement to the articular cartilage. Now, how to stand? This is also very important. Now, stand tall, sit straight. This is very, very important. And also lie. This is the very, very bad habit during the lying down position. So use of 2 to 3 pillows or much more larger pillows, that leads to complete reduction of this alignment of the spine. So this is very, very detrimental, and that increases the stress on the joints of the spine also. That can lead to damage of the facet joints. That can lead to extremely pain. So that is why sometimes even after the awakening from a good sleep, patient may complain of severe pain in the back or on the knee joint, because of this increased load is possible even during the sleeping. So you have to be aware that you have to use the proper pillow, and sometimes you have to use the side pillows also in between the thighs. So we have to that can reduce the load on the joints. Now, single most external factors which can increase the viscous elasticity of the weight-bearing joint is the symmetrical loading of the joint by the physical activity. How it helps? That reduces the interleukin-1 production of the damaged articular cartilage. Because symmetrical loading, I've already told, because of the symmetrical loading, the synovial fluid is circulated. And because as there's this increased synovial fluid circulation, that washes all the inflammatory and degradation product. And that degradation product of the cartilage, as it's washed away, that reduces the production of the interleukin-1, that is the most important inflammatory markers. Not only that, the symmetrical loading increases the lubricant synthesis and the synovial fluid. So this is this synovial fluid, it is increases, that provides much more nutrition to the articular cartilage. And the cartilage loading, there's a water, there's an aquaporin expression is also important, which is gradually squeezed out. If it is a continuous loading. So it is a continuous repetitive loading is absolutely banned, but it is a symmetrical loading, and within a permissible period. It's extremely important, because if it is a continuous loading, because of the continuous loading, water of the extracellular matrix is washed away, so that the cartilage becomes the lack of water, and that leads to increased strain on the tissue cells as the nuclear structure. So it is very, very important. So we have to do the optimized exercise. Don't do the over exercise. This is very, very important. And even those persons who don't exercise, simple walking is extremely important, as that can reduce the cartilage degradation. Now, there are several exercises, as you can see here, static and dynamic quadricep exercises, but don't forget to exercise the vastus medialis obliquus as the hamstring. How to increase the vastus medialis obliquus strength? So this is the strength. This is the exercise. So you can use a small ball in between the thighs, and you can just press it. And like this, there's the quadricep exercise with the help keeping the ball in between the thighs. This is most important. So right kind of exercise will increase the muscle strength, unloading the bone, and increase the flexibility and reduce the pain and stiffness. And another important, don't forget to strengthen your hamstring, because strengthening of both the agonist and the antagonist is required to unload the joint. Agonist is the quadriceps, antagonist is the hamstring. So if both the muscles are strong enough equally, that will unload the joint when the patient stands erect. That is how, if the patient stands for a long period, there will be no problem at all. That will be significant unloading of the joint. Not only that, we have to advise the patients to make the core strengthening exercise to increase the muscle strength of the trunk muscles also in this manner. As you can see here, not going into detail, I think everybody knows about it. And so there's some recommendations. So if there's orthopedic reviews, this is recommended. There's orthopedic joint unloading therapies, the weight loss, lateral wedge insoles, and the bracing. And physical therapy is the physiotherapy, thermotherapy, manual therapy, and transcutaneous electric nerve stimulation, and exercise and stretching. So for my patients, actually, I streamlined. How do you remember? So basically, it is a fire. So this is the technique of conservative management to reduce the progression. So basically, the rest, stretch, mobilize, and the strengthen. So basically, it's fire. What does it mean? Fire. We have to check your footwear. Your under surface of the footwear should not be very rigid. It should allow the shock absorption during your walking or during running. You have to apply ice, especially after the activity. We have to give proper rest to the muscles and proper exercises. Stretching of the iliotibial band is also sometimes required. Also, hamstring stretching is also required, and the calf stretching. Strengthening of the weak muscles is also required, as I've already highlighted. That is, hamstring and quadriceps both are simultaneously strengthened, and the medicines coming in the later part for reduction of the inflammation. Now, orthosis basically is the lateral wedge insole, and the offloader brace is most important. But these are initial phase that has to be used properly. Otherwise, that can lead to much more problem. So, is there any diet for prevention? Yes, extra virgin olive oil, rich in the antioxidants such as the vitamin E, A, and K in rats. It is experimented that suffering from osteoarthrosis, that's to prevention of the disease. So it is very, very important. We can use that. Now the drugs, there are several drugs. I'm not going to detail it. I think everybody knows it. Most important, powerful anti-inflammatory is coming in a big way. It is a pulmacoxib. So it's a pulmacoxib. It's a 2 milligram once daily dose. You can use for at least 3 weeks. So it can very rapidly, in contrast to other coxibs. Now it is coming in a big way because it is a cardio safe, it is a renal safe, as also the gastro safe. So that the very minimal side effects, where some objects that leads to little bit of pedal edema, which will observed within first 1 or 2 weeks. Ultimately, if you continue the drugs, that will goes away. So for first 3 weeks, it is sufficient enough for reduction of the inflammations that will break the pain spasm cycle that can increase the muscle strength by the activity. Now the diabetes mellitus, you have to control it. This is very, very important because that is directly related with the progression of the osteoarthrosis. How it can happen, this advanced glycation and end products, AGE, which is a short form, advanced glycation end product in the cartilage collagen, seems to be related with both the senescence of the cartilage matrix with reduction of the function of the chondrocytes. And with the passage of time, it is seen both the matrix and the chondrocytes tend to accumulate these age products. So it is directly to the diabetes mellitus. So if we control the diabetes, we can prevent the progression of the osteoarthrosis. Now there are semi-invasive management like the intra-articular viscosupplementation or intra-articular that is ozone therapy that can reduce the inflammation. Is a very inflammatory stage. Now, there are several surgical procedures. I'm not going to detail because this evening, we are trying to avoid the surgery. That is how I highlight what are the techniques to be taken for prevent the surgery. Now, because surgery is not the ultimate solution. So that is why there are several researches going on for advanced targets like ion channel inhibition, neurotropin inhibition, structural modification like targeting the osteogenic protein 1, fibroblast targeting the fibroblast growth factor 18, with the basically these are responsible for inflammation inside the articular cartilage. Not only the calcitonin, calciconvertin sulfate, ionos inhibition, and cell therapy. These are all experimental. Experiment is going on in spite of several improvement of the surgeries. That is why surgery is not the last answer. So take home message. Osteoarthrosis is the first one, is the primary because it is degenerative disease, which follows the osteoarthritis once the inflammation sets in. Early diagnosis, that is in the stage of the osteoarthrosis, is possible by the pain following inactivity. Sometimes I'm calling this cinema hall signs. Sometimes in the cinema hall, the patient, the subjects, any persons which is sitting for long time, once he start walking in the interval, patient feel pain, and during continuation of the movement, patient's pain goes away. I can tell it's the cinema hall sign. So that is a sign of early diagnosis of osteoarthrosis. And not only that, it is a microscopically damaged condition that can be diagnosed with the help of the investigations I've already highlighted. The rapid progressors can be identified because there are several external factors, and also there are some investigational parameters which can be used for identification of the rapid progressors, and the proper management like the pharmacological and the non-pharmacological, as well as the intra-articular viscosupplementation, that is a distal sodium channel block as an ozone therapy, can reduce the inflammation, as also can reduce the speed of the progression. All these modalities are beneficial for reduction of the progression, as also after the surgery, they may be beneficial for significant symptomatic relief. Thank you. Thank you. Over to
Thanks a lot, sir, for this enlightening lecture. And it's indeed a pleasure to listen to you how the simple techniques and simple methods can halt the progression of deadly disease and very devastating disease like osteoarthritis. So we would like to hear from you about your own clinical experience. By employing all these techniques, what are the chances to halt the progression of the osteoarthritis, and for how much duration means the progression can be halted?
Yes, basically it is a chronic disease.
Yes.
And basically in other sense, I've called it is a lifestyle disease. So if we can modify our lifestyle, so I've already told how the modification of lifestyle is possible. So the sports person, they can change their shoe patterns. They can change their activity. And if once they are diagnosed as osteoarthrosis, we have to do the exact diet. I've already how the diet helps. That they have not only that, they are the changing of the behavioral activity during their sitting posture, their standing posture, running, and also we have to avoid the high impact activities. So once you have diagnosed osteoarthrosis, patient should not have the jumping or any type of exercises which leads to high impact activities, that is leads to increased loading of the articular cartilage. So in that sense, if we at the same time, if we increase our muscle strength, not only the quadriceps, it is a common fallacy that we are concentrated on the quadriceps or we forget the hamstring. So if both the muscles are symmetrically strengthened equally, and that actually reduce the progression much more significantly. And even if we treat that some diseases, because some diseases are also responsible for progression, we can prevent the end stage arthritis. We can prevent the development, the requirement of the joint replacement, which is almost basically the amputation of the joint surface. So yes, so in that case, there are several other drugs, and I'm very much fortunate that some your companies also are taking providing this sort of drugs. The anti-natural collagen peptide is also very, very important.
Yes. So and you rightly said, means we will like to hear more about collagen peptide and apelapine role in osteoarthritis, and what's your own clinical experience with this?
Yes, that is if we pick up the diseases in the early osteoarthrosis stage, so these drugs are extremely beneficial. So if the first of all, we have to cut off the pain spasm cycle. And fortunately, there are several drugs. This polmacoxib is already come. So polmacoxib, along with some local rest, we can easily reduce the inflammation of the joint. So in that same time, if we start this anti-natural collagen peptide type 2, as also the apelapine. Apelapine is basically a product of the Boswellia serrata. It is AKBA product, and it is extremely anti-inflammatory function. It prevents the LOX pathway, and there are several anti-inflammatory markers they can block sufficiently for long period. And similarly, undenatured collagen peptide type 2, once that we ingest, we take it, that it will react with the Pierce patch. And this Pierce patch, all of you know, is very, very important. It is a gatekeeper. It is extremely important. We are very much highlighted with the role of the Pierce patch in the COVID situation, because if the patients who have much more COVID reaction, some patients have less COVID reaction. How it is possible? Because of the strength of the Pierce patch. So if the Pierce patch is very healthy, so that they can block the entry of this virus. So same thing has happened also. It is also in this case. So undenatured collagen peptide, if we ingest it in our gastrointestinal system, that will react on the Pierce patch, and the reaction of the Pierce patch with this undenatured collagen peptide type 2, they produce some anti-inflammatory cytokines. These anti-inflammatory cytokines that goes inside it. There's the interleukin 10. And that is transforming growth factor beta. These are the extremely beneficial anti-inflammatory cytokines that goes inside the system, and that's a good thing is, so wherever the inflammation in the body, they will react. So wherever it may be in the knee joint, wherever in the shoulder joint, wherever in the wrist joint, everywhere they will react rapidly. So there's a natural production of these cytokines by the body is extremely good things. So this is the way the undenatured collagen peptide works. At the same time, the aflapine is a Bacillus serrata product. So that will have directly on reduction of the inflammation inside the joint. So basically, it's a joint specific. So that is extremely helpful for reduction of the inflammation. And also if we use this polmacoxib and the local rest to the joint, that will definitely cut off the pain spasm cycle and reduces the inflammation. That will prevent the transition of the stage from osteoarthrosis to osteoarthritis stage. So that is extremely beneficial. So you have to identify the early stage of the osteoarthritis.
So, for a long time, maybe in country like India, etocoxib is being used very widely, and it's very readily available. The treatment is also economical. So what is your experience of treating such patient with etocoxib in comparison with other NSAIDs?
Yes, you are right. There are celecoxib dynasty, the coxib dynasty actually. They have started in a big way, celecoxib, rofecoxib, valdecoxib, and ultimately everybody is disappeared. And ultimately the etocoxib remains. So how it happens? So there are several other problems like the rofecoxib, celecoxib. Celecoxib is now it is coming in a small content by different workers, but rofecoxib is a very, very bad thing, because ultimately there leads to some catastrophic damage to the cardiac events. So that is why ultimately it becomes banned. Valdecoxib is also same thing. Now, etocoxib is a selective COX inhibitor, but it actually basically it acts on these selective COX2 enzymes. But the problem is etocoxib is if it cannot give for long period, because in the osteoarthrosis is a chronic disease. We have to use this anti-inflammation for long period, at least for 6 weeks. So in that case, if we use the etocoxib for more than 2 to 3 weeks, what happens? There is a chance of the same thing, the cardiac toxicity. There's an increased chance of hypertension. There is some there are some swelling. There's a fluid retention by the in the renal blockage of the prostacyclin. So these are the problems are coming. So that is how the etocoxib cannot be continued for long time. Now we are very much fortunate to have the polmacoxib, and the polmacoxib starts its action because it has a dual mode of action. Not only it blocks the coxibs, but also it blocks the carbonic anhydrase. So because it is readily, carbonic anhydrase enzyme is readily available, which acts as a buffer system. So if the carbonic anhydrase, because of the, if it in some areas where the coxib is not required, suppose if we want to have some reduce inflammation in the joint, we don't want to act on the heart. So it comes in the heart, but it reacts with the carbonic anhydrase. So that is how the effect of coxibs blockage is protected. So that is how the heart is protected from the polmacoxib. So that is the beauty of the polmacoxib. So it is a cardio safe, renal safe, and also the gastro safe.
Sure, sir. So you have already elaborately mentioned about the posture, the kind of exercises which are required, and you are very much focused on prevention strategies and means how to halt the progression, how to diagnose it early. So extensively and elaborately you enlightened all the audiences about the same. Now we are towards the end. So we thank you for this enlightening lecture from the marketeers of Etobrix and Hapid. So for formal vote of thanks, I invite Mr. Gautam Chakravarti, who is Vice President of Sales and Marketing at Wockhardt for two large divisions, that is Marine Division as well as Antibiotic Discovery Division. So I hand over the forum to Mr. Gautam Chakravarti. Over to you, Mr. Gautam.
Thank you very much, Dr. Ravi, for the invitation to give vote of thanks to Dr. A.K. Pal. It's my pleasure because almost close to 2 decades, I am personally in touch with Dr. Pal, and we have done multiple programs in presence and with his help, because Marine, particularly as a division, it's a purely ortho-focused division, because majority of the brands are falling into ortho basket, and we have done many such programs, and I have heard him many times. Dr. Pal is having huge knowledge about the subject, and when he speaks with so much of confidence and authority. It's lovely to hear him time and again, and I'm sure all the delegates must definitely have enjoyed his lucid presentation. So thank you very much, Dr. Pal and sir, for coming and honoring this session and speaking on behalf of us. OrthoTV, we are continuously doing program because we are serious about the specialty. And not only specialty, we have identified our areas where in the different, disease segment, we are very focused towards pain. We are focused towards osteoarthritis, and definitely we have already entered into the osteoporosis area. And we have launched also Terityde as a brand of teriparatide. But we are also contemplating the denosumab in a very short period of time. And of course, we are eyeing for abaloparatide, which is going to be off-patented soon. And I'm giving you guarantee that Wockhardt Marine is going to bring that product. Obviously, one of the first mover into Indian market. So, sir, it is not about organizations are, doing business. Wockhardt is a company which investing crores and crores of rupees into the R&D, research and development, and that is the reason that now the huge division has come with the antibiotic discovery division, and I have been given charge for that also. And I'm proud to say that already we have launched last 3 years back. That is one of the gram-positive, that is our MROC, that is levonadifloxacin, into the market. For orthopedicians, yes, now probably along with that division, Marine is also going to having a co-marketing. So because Marine is having a much bigger field force, because antibiotic discovery division is operating majorly with the intensivist and the ID specialist. But we are going to operate this brand purely from the ortho, where in BGI, we are going to promote it, bone and joint infection. And where you are doing, or all the orthopedicians are doing knee surgeries, there definitely you can use it as a very good antibiotic, where you can find this wonderful product. And good news to share that very soon we are going to bring another gram-positive. It is also a number at this point of time, because we have not yet given the brand name. And in coming 1.5 years, we are also going to bring another gram-negative. So, proud moment to announce that Wockhardt, being an organization, Indian multinational, is having a pipeline of new generation antibiotics, the research of the own. I believe many of the multinational companies are not having such kind of pipeline in the international market. So this is called, whatever our Prime Minister always says, that make in India. So that is what we are all proud about Wockhardt, to have make in India antibiotics. So I will definitely look forward for all the medical fraternities and especially orthopedicians. And thank you very much, all the delegates, to spare time and come and join this OrthoTV. This program will be on in future in multiple series. I'm sure that we will have Dr. Pal once more for some other topic. Thank you, sir. Thank you very much. And thanks to all, and thanks to OrthoTV for giving us chance. Thank you very much. Thanks a lot.
Thanks a lot, Dr. Gautam. Ms. Gautam, and of course, Professor Pal is always stalwart in this field, and his guidance is very, very important. I also thank all the Marine Division or colleagues and friends. So, with kind permission of sir, I declare that this program is over, and have a good night. Thank you, sir.
Thank
And
you, sir.
thank you all delegates.
Thank you very much.
Bye.
Thanks a lot.
Thank you, sir.
Bye, sir.